Good morning, everybody. Welcome to the December public board meeting for the CQC. Sadly, we are back on Teams, obviously following government guidance, which I fully support, but it is a shame because I think we were just getting back into the swing of being in face-to-face meetings with the benefits that brings. So anyway, we are all here with the exception of Ali Hassan, whose birthday it is today. Ali, if you happen to be watching this, happy 40th birthday. Mrs. Hassan has made it very clear that Ali's priority is not to be in our board meeting today, so that's why he's an apology, and Mark Sutton is an apology because unfortunately he is ill. I want to welcome Tevfik Balagan, who is the from CQC Equality Network. He's our network representative today. You're extremely welcome, and put up your hand if you want to come in at any point during the discussions. I also I'm going to invite you to introduce yourself at this stage in order to save myself the embarrassment of mispronouncing your name. So would you just like to introduce yourself and correct my pronunciation?
Thank you. My name is Radojka Miljevic. I'm a partner at Campbell Tickell, and I'm here as someone who's led the board effectiveness review of the CQC board,
which is on our agenda for a little bit later this morning. And you're extremely welcome, both for your session, but for the whole meeting, obviously, if you wish to stay. I think that's the introductions. Does anybody have any declaration of interest they need to make beyond the ones already formally made? Okay, that's good. I think that takes us then to the minutes of the meeting we had on the 17th of November. Are they a true and accurate record? Excellent. I don't think there's one item on the action log which isn't yet due, so we can put that on one side. Is there anything arising anybody wants to raise? Okay, Ian, let's come to you then, please, and the executive team report.
Thanks very much, Peter, and good morning, everybody. You'll see in the papers that in my section, I wanted just to talk about our operational stance at the moment. And when we put the papers together, we included in the papers a statement from the three chief inspectors in terms of our ambition around inspection over the coming few months. In some respects, that statement is a restatement of the sort of work that we've been doing over the past few months. However, since the papers were published, the Omicron virus has accelerated very dramatically, and you've seen events over the weekend and the early part of this week. We've therefore taken the decision to change our operating stance, and some of that is potentially significant, some of which will be about continuing with the sort of activities that we have been doing, but moving our resources around, moving our focus around over the next certainly over the next few weeks, and possibly longer than that. I'm going to ask my colleagues just to talk about their particular areas, starting off with Ted, then Rosie, and then Kate in terms of the three chief inspectors. I'm also going to followed by Tyson, who's going to talk about the way we are organising ourselves from a people point of view, and then finally picking up with Kirsty, who's just going to talk about registration and the changes we will want to make there as well. And then I'll come back to me and I'll just talk about what we think our contribution might be around volunteering around the vaccination programme. So if I can hand over to Ted at this point. Thanks, Ted.
Thank you, Ian. As we'll be discussing later in the agenda, the acute services urgent emergency care is under enormous pressure at the moment. So we fully support the priority being given to the booster rollout programme. The surge in Omicron cases is clearly an extra pressure on those services, and I think doing everything we can to protect them from that extra pressure is a real priority. So we very much support the booster programme, and I think it's really important we do everything we can to facilitate and encourage providers to do that as effectively as possible. In view of that, we have postponed our inspections and other regulatory activity for NHS providers who are providing are supporting the booster rollout program, also to some independent healthcare providers who are supporting the booster rollout program. And the main criteria is they're involved in the program, and we don't want in any way to detract them from the priority of the program going forward. We will still monitor care as closely as we can, and we will reserve the right to take action or inspect if there are exceptionally severe problems in any particular service. So we're not saying we won't inspect, but we are postponing our planned inspections for the time being. I should say those services that are not directly affected by the booster program or involved in it, we will continue with the approach we outlined in the communication we put out last week. And I particularly stress we will continue to take our approach to inspecting and regulating mental health services, independent healthcare services not involved in the booster program, and we will be continuing our Mental Health Act reviews and SOAD visits to protect people who are detained under the Mental Health Act. So that's the plans in the Hospitals Directorate. So shall I hand over to Rosie at this stage? Rosie?
Thank you very much, Ted. And we are taking a similar approach to TED in primary medical services and integrated care. Can I just start by saying thank you to all my colleagues working flat out in general practice at the moment to roll out and accelerate the booster programme, which clearly is a huge priority at the moment, and they're doing that on an already highly busy and demanding day job. So thank you to everyone who's involved in that. So in primary medical services, we are also pausing all inspections in general practice and urgent care services, except where we see evidence of risk to life or risk of serious harm. And all of those decisions will be to inspect will be signed off by myself. We are continuing in oral health and independent health to take a risk-based approach, and that work will continue, but that is under review if those areas become involved in the booster programme in any way. And our work with Health and Justice and the Children's Services work will also continue as planned. So that's the situation in PMS. If I could now hand over to Kate. Thank you, Kate.
Thanks, Rosie. So I'm just going to update you on our efforts in adult social care. So there are 3 priorities in adult social care as we move forward through this winter. The first is continuing to respond to risk and undertake inspections as a result of information we have of concern from the public, from information we hold, and from people who work in the sector. So the first priority is responding to risk and undertaking inspections. The second priority is about an increased focus on our number of infection prevention control inspections, and also standing ready to respond to an increase in requests for us to go out and look at the quality of potential new designation settings. So the reason why this work matters is good infection prevention control in care homes keeps people safe and well. It also supports with avoiding unnecessary hospital admissions. Good infection prevention control stops care homes needing to shut their doors, and can also support timely discharges as well. So our second priority is around infection prevention control, because it's the right thing to do for residents of care homes, but also to ensure that those care homes remain open for people being discharged from hospital if that's where those people need to end up. And then our third priority in adult social care is how we can take action to support the increase in capacity available in the system. So there's 2 things we're going to do under that priority. We are going to proactively go out and inspect and rate services that are registered with us but are not yet rated. And we know that good commissioners don't purchase from services that don't have a rating, so we're going to do that. And the second piece of work is we're going to go out and re-rate services that requires improvement, where all the evidence tells us that should we go out and have a look and inspect the service, we would likely re-rate it as good. And again, responsible commissioners would be looking to purchase from good services rather than services of a lower standard of quality. So three priorities in adult social care that are the right priorities to do for the adult social care sector, but will also support system efforts in terms of ensuring avoidable admissions to hospital, timely discharges, and ensuring that we're doing everything we can to increase the capacity available in the social care sector. I'm going to hand over to Tyson now to talk about the delivery of these ambitions. Tyson.
Great, thank you, Kate. We see this as very much a cross-CQC effort, both to bolster the numbers in our adult social care and also to increase our registration work, which I think Kirsty will talk about. This is so that we can increase capacity across the whole of the system. As Kate said, this involves maximising the number of people, including inspectors from primary medical services and hospitals, who are able to undertake our new adult social care inspection priorities, as well as enhancing the registration team so they're able to bring new social care providers into the market. Over the last 24 hours, I've begun working with the senior leaders and also the planners from across the operational directorates and also across our corporate functions to plan this work. And I hope that over the next day or so, to be able to identify the number of additional people we can mobilise from outside adult social care and registration, and how we can train and deploy them in a timely manner. I'm not able to give it exact numbers at the moment in terms of how many people we can deploy or how many inspections they can undertake, as the situation is still very fluid. I'm hoping that it will start to crystallise over the next day or so. But I'm hoping that as a result of this work, we can give the registration teams the additional capacity they need, as well as support several hundred additional inspections across all of the priorities we have identified for adult social care. Over to you, Kirsty.
Thank you, Tyson. So very briefly, in terms of registration, what we'll be looking to do is to maintain our capacity and also focus on those applications which adds capacity into the system. So we will be prioritising anything that enables us to do step-down care or any new models of care which will support, particularly in social care, bringing capacity to enable flow through the system. We'll also look to move some resources into registration so that we can enable us to keep ensuring that we're not letting our backlog of other registration applications creep up. So that's fine. And over to you, back to you, Ian. Thank you.
Thanks, Kirsty. So having done all of this, what we believe that we will have the opportunity to release some of our people to directly support the vaccination programme, being part of vaccination teams. As Tyson said, he's doing some modelling work on this now, so we can properly scale that. We believe that the work that we do internally must take first priority, but we do think there is definitely an opportunity to release some people to support the vaccination teams. We have, for the last few weeks, made an open offer to our clinically trained staff that if they wish to return to frontline medical care, they've been able to do that. We know we have a small number of people. I think there is a common misconception out there that we employ lots and lots of doctors and nurses, and we actually don't. We actually employ relatively few doctors and nurses and other clinically trained staff. What we tend to do is we draw on expertise from specialist advisors as part of our inspection activity. So whilst not doing the inspections that, as Rosie and Ted were describing, will indirectly release people back into the NHS, there aren't large numbers of clinicians that we can push towards the vaccination programme. That said, though, we do think some of our people, can take part in other roles in vaccination teams in order to support the wider national effort. So I hope that gives board members and the public a sense of our approach here. And of course, we had to move incredibly quickly over the last few days. So we asked Peter to give us authorization to change our operating stance in the way that we've described through a chair's action. So I think, Peter, I'd be grateful if as part of this discussion we could agree the chair's action and note the chair's action for the benefit of the minutes. Thanks, Peter.
No, thanks, Ian. I think, although somebody will correct me, I think this is probably only the first chair's action that I've taken in 6 years, so it's a mark of the emergency that we're in. But can I just have board approval to endorse the action I took? Good, thank you very much indeed. And Ian and colleagues, I mean, it seems to me that the really big contribution that CQC can make as an organisation to the emergency is all around increasing capacity, as you've all been talking about, and doing it in a safe way. And I think this is really important that we focus on those things.
I think that's right, Peter. I think one of the things that we offer, I think, is this perspective of being able to peep over the horizon, because I think obviously everybody's worried about what's happening today and in the next week or so, whereas I think that the things that we're starting to think about is how is the system, how is the how are all of the providers in the system going to fare end of January, end of February, because this is not suddenly just going to go away once in the next 3 or 4 weeks. So I think we're trying to think about what are the impacts for the medium to long term. Hence this big focus on adult social care, the big focus on capacity building, so that the system has got a route out of what is undoubtedly an incredibly difficult time.
Yeah, thank you. And does anybody want to ask anything or add anything on our regulatory approach before we move on? Robert.
Thank you. I'm very appreciative of the action that's been taken. I think it's obviously necessary. The question I had, Ray, was really for Rosie. It was about the knock-on consequences of all this for potentially in relation to GPs. We know from previous experience that there's been a challenge, and this is no criticism of GPs at all, of people getting access, mitigated to some extent by much greater use of e-consultations. But the concern has been and remains, I think, certainly in Health Watch, that potentially disadvantages some people who in disadvantaged areas and from disadvantaged backgrounds. And while appreciating the need to withdraw inspections and so on, I wonder how, if at all, we are able to continue monitoring this and drawing attention to any particular issues that arise in particular places.
Thank you, Robert, and a really important question, because I think what we have to recognise as well is there is a lot of poorly people who don't have COVID or COVID-related illnesses, and we need to make sure that they get appropriate care, particularly with serious illnesses such as heart conditions, stroke, serious mental health issues, early cancer. And we should learn the lessons from the first wave of the pandemic, where we heard about a lot of people having delayed referrals and delayed diagnosis of cancer, for example, as a result of people not accessing care. So I think the first thing I would like to say is to the public who are listening to this, please do, if you have symptoms that are worrying you, if you have persistent symptoms, if they're not going away, and if you're worried about something serious, please do access care, because it is important to get those symptoms checked up and seen. I think GPs are in a very difficult position because they have a huge demands on their time. They were already under significant demand from this race to booster of jab everyone, and that was causing immense pressure on their services. Clearly now vaccination is a priority for them, and I think the problem with when you're a GP is that actually some things it's not always straightforward to work out what's a serious condition and what's a straightforward condition. A child with a minor viral type symptoms can develop into a child with meningitis within a few hours, and so it's how do you fish out what's important and what's serious and what's not serious. I think I understand the system is doing some work looking at how they support general practice to prioritise during these difficult times, which I think will be very much welcome. What I would say is that this is vitally important that all parts of the system work together to deal with these challenges, and that all parts of the system are used appropriately. So people get signposted to places like pharmacies, to dentists if you've got toothache, and other places, and make sure that all parts of the system work collectively to deal with what's going to be enormous challenges. I think it's going to be also really important that CCGs have clear contingency plans if practices are impacted by people who get sick and poorly, and that impacts on the practice ability to deliver. So access to general practice is something we were looking at in more detail before the last week. We will continue to follow up any concerns that are raised with us, albeit we won't be undertaking inspections unless there are very severe concerns to risk to life. But it is something that we will want to keep under review very closely, given the level of concerns we are hearing about.
Thanks, Rosie. Teofik.
Thank you very much, Peter. As part of our immediate regulatory response to recent COVID-19 strain, we've now stepped away from routine inspection activity. How confident are we to ward off any legal issues that might emerge from that singular decision, possibly from key stakeholders? Thank you, Peter.
So I'll start by making the comment, Teofik, that inspection is only one of the things that we have in our armory, and whilst we are stopping, except in these sort of extreme circumstances, some of our on-site inspections, we're not stopping regulating and we're not stopping monitoring. So you know, we are still doing our job, albeit in a slightly different way for a short period of time. That would be my answer. Ian, do you want to add?
I was going to broadly say what you've just said, but I think in addition, I think it's a difficult balance to strike, and I know that providers will be having the same conversations. It is of course possible that we could be legally challenged, or individual providers could be legally challenged, but I think we have to recognise that we are where we are in terms of the national emergency. So I think we are in a broadly safe place. But we don't know what we don't know until we're challenged. I don't know whether Rebecca has a point of view on this.
I would only add that we have been very clear that where we do have evidence of a risk to life or serious harm, we will go out and take action. So I think it's just a question of striking a balance between that high risk of harm to patients and obviously the need to maintain services and not want to be a burden on providers who are really very stretched and at the front line of this. So it's just that balancing act. But I think the steps we've taken have got very broad support. So my personal view is the risk is actually low.
Thank you very much. Thank you.
Thanks, Teofik. Jora.
Yeah, just a question for Ian. Ian, previously we used I think it was the Emergency Support Framework, the ESF. Are we resurrecting that for a period of time, or are we using some other way of collecting data and information?
We're not resurrecting that in direct terms at this point, but one of the pieces of work that Tyson and colleagues are doing is to look at exactly how we'll do our work. In broad terms, the work we do in adult social care will continue to be the way we have worked over the last year or so, particularly in order to get to a rating, because I think that, a lot of the work is about getting to a rating. The IPC inspection methodology is a methodology in a box, if you will, and that's fairly straightforward. So we're not going to do widespread ESFs at the moment, but I think, as I said earlier on, I think I am concerned about the medium to long, or medium in this context of greater than post-Christmas, medium to long term. I think we may have to look at our regulatory position sort of into January, early part of February. Again, I think we will have to keep this under review. So we as an exec team are going to formally review the position on the 4th of January, and we'll do subsequent reviews after that. But I think we need to be reasonably open-minded and fleet of foot on this. So, but at the moment, I think what we're saying is just stepping back from mainstream NHS services, but predominantly everything else remains the same, and then redeploying people into support the adult social care area, and then we'll see how it goes over the next couple of weeks. This is a specific response to the booster program, really, rather than broader pressure. I think we will have to review that, but I think it's something we're certainly open to.
So I think it's really important that we maintain our focus on our primary objective, as set out in the statute, which is to ensure people get safe care. And clearly, if hospitals end up being overwhelmed and people are unable to get access to the care that they need in hospitals, then that is as big a problem as an individual not being able to get safe care somewhere else. So I think if you look at it holistically, what we're trying to do is balance the need to try and keep the pressure off the NHS as much as we can play our part in that, and at the same time making sure that individual providers are doing what they're supposed to be doing to provide safe care. So I think we're doing the right things is what I'm trying to say. And thanks everybody in the executive team who've been working incredibly hard over the last few days to move us quite rapidly into a slightly different operating model. So thank you.
Thanks, Peter. So if there's nothing else on the point about operational readiness, going to hand over to Kate to talk about the Adult Social Care Reform White Paper.
Thank you. And so I'm going to talk about the white paper and workforce, and then I'm going to talk about out of sight and closed cultures. So since we last met as a board, the long-awaited white paper into adult social care was published, something we've been calling for a long time as a regulator, which was a kind of ambitious long-term vision for social care with the funding to deliver that vision. So very pleased that is now with us. Been really interested in the focus on workforce within the white paper. So as you know, in State of Care back in September, October of this year, we flagged the rising vacancy rates, particularly in care homes, that went from 6% to 10.2% between April and September of this year. And we called for action to support the social care workforce who were exhausted and depleted. Around the time of the State of Care publication, the government announced an additional 162.5 million for the social care workforce, and a further 300 million was announced for the workforce last week. We are really keen to see that money flow rapidly through to the front line. It's highly unlikely that the large number of vacancies in social care will be filled between now and Christmas, and over Christmas, a time when we are most concerned about workforce capacity. But actually, if actions can be taken to reduce the turnover rates within social care, which is particularly high, that may go some way to address the kind of significant challenges. So really welcome that we've got a white paper. We will keep a continued focus on the impact on that in terms of market fragility, and are really keen to see that additional money announced to the workforce flowing straight through. And on the topic of workforce, we've been keeping a very close eye on social care workforce. We had vaccination as a condition of deployment for care homes go live on the 11th of November. We have a number of concerns about how the social care workforce is going to cope through the winter. So this week we've introduced a couple of additional questions into our inspection activity. So when we go out and inspect providers, and when we have monitoring calls for social care providers, we are going to be asking them about what impact workforce is having on their ability to deliver quality care. And that will help inform us about what's going on at an individual provider level, but it will also help us aggregate that up to understand what the national picture is about the challenges around recruitment and retention in social care on the ability to deliver high quality care. We're also keeping a really close eye on deregistrations. There's been a degree of nervousness about whether we might see providers exiting the market. To date, we haven't seen that materialise, but we will continue to keep a very close eye on that and report on it as well. So lots of focus on the social care workforce because it's important for people who receive social care. We also know that if there's a big blockage when it comes to the social care workforce, that very rapidly has an impact on all other parts of the health system as well. Just going to move out of sight and then on to closed cultures, if I may. So out of sight, we published our interim report in December that looked at what changes have been made since our original report into restraint, seclusion and segregation. What that interim report found was that there has been some progress, but not enough, and that people are still being subject to restraint, seclusion and segregation in a way that we would not want to see happen. We will be publishing in spring a full report into the findings of Out of Sight, and I look forward to talking to board more about that then. And then just very briefly, just to keep the closed culture theme going, we've talked about this pretty consistently over the last year, 18 months. So we are rolling out our quality of life tool, which, as board knows, is our new tool designed to really understand what people's experiences are of receiving care. We're piloting our Talking Mats tool, and in the new year, we will be formally closing down the project around closed cultures, which has been a mammoth program of activity. But we will also be having a conversation with board in the new year about impact. So the exam question is, has all this activity made us more effective at identifying and spotting services at risk of closed cultures and taking action? So again, I look forward to a follow-up conversation with board in the new year on that. Thank you, Peter and Ian.
Thanks, Kate. Mark Saxton wanted to come in, I think.
Thank you, Chairman, and thank you, Kate, for a very, very full report. Could I just come back to the outer site report, and then also I would just like to talk a bit about the workforce survey tool. But the outer site report, this continues to be really critical for us and very, very critical for the service users. And so not to hear of great improvements, to hear about challenges around provision of community support, providers not giving the right care or providing the right skilled staff to meet specialist needs of people is, just demonstrates how important it is that we don't lose sight of this. But within the report, there becomes an issue that I think is very important to us strategically. I mean, we have a strategic aim to deliver smarter regulation, and yet we learn that data from NHS Digital is unable to tell us how many people, autistic people and people with a learning disability are receiving inpatient care at any time, which I think is a real challenge for us strategically. And the report goes on to say about large discrepancies between commissioner reported figures and reported figures from providers. So as I said, this has a real strategic issue for us in terms of how we want to operate in the future using data. So perhaps it's not fair to ask you this question, Kate, but I feel that this is something that we need to come back to and review and consider. And in terms of the report going forward, can I encourage that in the spring report, we continue to hear those powerful stories? Because when you read Sally's and Tracy's stories, you really get to understand how critical this issue is. So could I encourage the report in spring to have more stories in it to help us to understand the issue more? In terms of the workforce tool, I think this is great to be asking these questions into the sector, but is there going to be a vehicle whereby when we uncover some best practice, employment practice, could this be shared with all providers? So those are my two questions, please, Kate.
Lovely.
Kate, let me bring Stephen in and then come back to you, Kate, because
Sure.
I think Stephen may be covering some of the same ground or maybe different, but anyway, Stephen.
Great, thank you, Peter, and thank you, Kate, for a really helpful report. Yes, you're right, I did want to pick up the workforce issues. Just to sort of congratulate you on the positioning of this within the white paper. I know it's reflected a lot of effort on your part to sort of make sure that the importance of this whole agenda was there. My question was kind of, despite your huge energy and skill, I'm not sure you alone can get us to where we need to be in terms of, the right workforce developed in the right way for the long term. Do we have the right forum for partners to sort of come together? Because we've got a range of other organisations who really need to play a role in building the right workforce for the future. Is that forum there? Do you see our partners kind of leaning into this agenda? That was my question. Thank you.
Thanks, Stephen. Kate.
Great. Okay, let's go through that in order. So thank you Thank you, Mark. So the issue around out of sight, so the report we published, almost 18 months ago now, talked about it's hugely complex. So people end up in inpatient units a long way away from the family home because there isn't that consistent crisis response in the community. And despite there being really good buy-in from every part of the system, NHS England, local commissioners, local government, providers, advocacy groups, us as the regulator, it's still been incredibly hard to turn the dial. So there's still over 2,000 people as inpatient units today. And we know that for many of those inpatients, there isn't that unrelenting focus on getting them back home. And often they are not receiving therapeutic intervention and they're in an environment that exacerbates their distress rather than enhances it. So it's hugely complex. It is disappointing we haven't made as much progress as we would like, but we will absolutely continue to focus on this agenda. And Mark, the action we're taking from a regulatory perspective to ensure that poor quality services don't continue to deliver care if they can't make the improvements we'd expect. The data thing, when we originally published Out of Sight, the issue with data, what was interesting about it was there were many different understandings about what constituted restraint, seclusion and segregation. And coupled with that, in social care, there was no and is no national reporting mechanism anyway. So social care providers do not have a current mechanism for reporting when restraint, seclusion and segregation happens. And that was something we were calling for to be put in place. I agree with you, Mark. I think the people's stories that were woven throughout the original report really brought to life. So it may be a smallish number of people, 2,000 people receiving these sorts of care, but the impact on each of those individuals on their human rights and their quality of life is so significant. That's why this is an agenda that we absolutely won't drop. And I will take back to the team your request for more stories in the final report. I would also like that as well, because I think it brings the topic to life. Question about the workforce tool and how we can capture best practice. So we are always really eager in all of our regulatory activity where we see stuff's good that we can talk about it and capture it. As to exactly what that would look like, can I come back and update board? So the workforce tool would have been live for about a month in January. Can I just give you an update then about how we plan to do that, Mark, if that's okay? And then Stephen's conversation about workforce and where have we got all the right people in the room? So there are a number of very influential bodies on this. We've got Skills for Care and Health Education England and the Social Care Institute for Excellence, to name but a few. I think Local Act Personal, etc. There are regular conversations between all those bodies who are all busily trying to influence alongside us about ensuring that we end up with a workforce that's valued, recognised and rewarded accordingly. So I'm going to a meeting first thing tomorrow morning to talk about the white paper, the additional money with all those partners to say what else do we need to be doing next. So I would say yes in response to Stephen's question. Thank you.
Great. I'm very disappointed, Kate, the suggestion that single-handedly you can't solve all these problems immediately. But anyway, seriously, thanks very much for all you and colleagues are doing. I mean, these are just such important areas and very appreciative of the work that's ongoing. Ted, do we come to you now?
Yes, I'll be brief because we're going to be talking about urgent and emergency care in a few minutes' time, and I don't want to cover that in this section. But just to say that we did start some inspections of urgent and emergency care systems. It was, I think, a good model of inspection. It's got good feedback from providers and systems. We've stopped those now as part of our postponement, but we'll be looking to take them up as soon as we can without having an impact on the capacity around the booster programme. Can I just highlight one thing in my report that I think is significant, is actually relevant to what Kate was just talking about in terms of out of sight, and that is the Community Mental Health Services review. This is our annual review of patients' experience of community mental health services. This is always the review of patients' experience that gets the worst results, and this year's results are worse than ever. And I think it is a reflection of the enormous pressures on those services and the difficulty that people have had accessing community health services. And of course, that has a knock-on consequence in that if they cannot get the care they need in terms of accessing the therapy they need or accessing the crisis support they need, people's mental health may well deteriorate. They may well end up in an accident emergency department inappropriately, they may well end up being admitted to inpatient facilities inappropriately. And I think there is a real message coming out of this survey, which has been present for years, but is worse in this year, I think, than previously, presumably because of the pandemic. But this was not caused by the pandemic; it may have been exacerbated by the pandemic. That people cannot access the services they require for their mental health support in the community in a timely way, and this is something the system does need to address.
Thanks, Ted. Kirsty.
I'll take that bit if it's performance.
Straight over.
Okay, Chris. Okay.
Yeah.
Straight over, Chris.
So this just a few updates for me. Update from October. So just a couple of areas to pull out. We continue to monitor our regulatory activity with registered providers. We've had 41.1% for the year to date, which is either a DMA or an inspection, and making judgments against 60% of registered services when you incorporate the published statements. Obviously, all of this is at the end of October, so the discussions we've had are obviously going to impact on our performance for the year, and we'll be looking at that in the coming months and how our reprioritisation affects our delivery. In give feedback on care, I mentioned this last month as part of the quarterly update. We continue to look at just kind of diving into the information that we've had back. It is really invaluable and some interesting insights. We've had 65% increase year to date, which is 151% increase in PMS, 70% increase in the hospital sector, and a 36% increase in adult social care. So across the board increases, more specific in certain areas, and quite a lot of positive feedback coming through as well. We've seen increases in positive feedback coming through, so we continue to analyse all of that information. In registration, continue tracking well with average days to complete registration applications, reducing. Simple is down 7.4%, normal is down 12%, so we're reducing the time it takes us to do them, both of which we're aiming for 15% by the end of the year as a reduction. That work will and does stand us in good stead to support the focus on capacity that we talked about earlier. And final area for me in terms of our finances, so underspent by 9.3 million to the end of October. That is forecast to increase to 11.3 by the end of the financial year. On capital, we have a 2.9 million underspend year to date, and that's forecast to increase to 3.5 million, although we're just looking at that, as I think that is probably overstated, and I think that'll be closer to budget than we've indicated there at that point in time. So that's it from me, Peter.
Thanks, Chris. One day I remembered that you deal with this without an introduction from Kirsty. I apologise to both of you. Anybody want to? Yes, Mark Saxton.
Thanks, Chairman. And I just wanted to congratulate the executive team on the virtual conference in terms of reaching out to our people. I thought it was excellent. I dipped in and out. But I thought it was a tremendous sort of second year repeat of this engagement exercise. I just wondered if you've had any feedback as an executive team on it. But congratulations anyway. I thought it was super.
Do you want me to take that one? So yeah, so our average score in terms of sort of overall happiness with the conference has gone up from, I think it was 8, it's gone up to 8.3 or 8.7. I can't quite remember off the top of my head, but a continual increase in terms of people enjoying it and saying it added value. Plus, we had on most days well over 1,000 people on the platform, and at peak times we had over 2,000 people joining. So really well attended and really positive feedback across the board from most of the speakers and the activities that were run.
Yeah, I thought it was superb as well. Sally.
Thanks, Peter. And yeah, I thought the conference was excellent. I just had a query on performance with Chris, if that's okay, and you might come on to talk about more detail, Chris, but it's about the inspection activity that we've undertaken to date. So one of the figures talks about having undertaken review of around 14% of providers. And obviously there are many thousands of providers, but that felt quite low in terms of what I would normally expect to see. And yet I know there have been a huge range of monitoring activity, certainly. So have I got the wrong sense of whether 14% year-to-date contact with providers is a low figure?
I mean, we haven't set a target for this, so it's something we track throughout the year. It is probably below where we'd like it to be, so we're just looking at, or we were in previous months looking at how we could increase that volume of activity. We need to just bear in mind the discussions we've had before about how that course corrects where we're at. But it's as I say, it's not something we've set a target for, but it is slightly under where we'd expect it to be.
Okay. And I just wanted to ask Ian a follow-up question, I suppose. I absolutely support the action we've taken around pausing inspections, but do we have any sense of what it might look like after the first few weeks into the new year, or are we just going to take it as it comes?
I think we're going to do a review as an exec team on the 4th of January, immediately post Christmas. I think depending on where the vaccination program is at that point, I think we will make a determination as to whether we can sensibly resume the work we have been doing over the last few months. I think we were already concerned about any perceived burden we were placing on providers more generally anyway on the run into winter. My sense at the moment is the vaccine program will still be running at full chat during January. I think that would be a reasonable expectation. So I think we'll look on the 4th, and then we'll take a view then. I am quite keen to see if we can sort of do this in a reasonably staged process. I don't particularly like, making a decision over the weekend to for an announcement on Monday morning if we can avoid it. I think it was inevitable this weekend, but I think I want to try and see if we get into a sensible drumbeat. I think, I suppose linking your question to what Jura was saying earlier on, I think one of the questions for us is, what can we do? What valuable work can we do off-site? How can we maximize that? And I think we've been doing a lot of that sort of stuff behind the scenes, in terms of reviewing regulatory history, reviewing whether there's been any contact from the public. Those sorts of things have been checked on a routine basis. But we're trying to run this balance, or strike this balance between a high-end regulatory contact, which involves crossing the threshold and so forth, versus doing things behind the scenes. We know that a number of providers, certainly in adult social care at the beginning of the pandemic, really valued the telephone contact we were making with providers, because we were able to identify and slightly codify some of the big issues. PPE was a big issue, you'll recall, and we were able to pass that back to the department. My sense is we might be back into that sort of territory, and we just need to think about how we can capture information quite carefully. I think that the lessons we've learned around the way we use our systems now, and the work that we've done to develop them, is really powerful. Kate alluded earlier on to sort of capturing information from the workforce. Well, that's actually the way that's mechanically done is through additional questions on the new reg platform. Which is essentially a development of the ESF, a development of the direct monitoring tools. So we're building these tool sets out. So I suspect we'll get to January. I want to then see if we can make a view that's sort of probably at least 1 quarter long. We did this at the beginning of the pandemic. We tried to adopt a regulatory stance for an entire quarter and then review it on a quarter by quarter basis, because it gave our own teams certainty, but it also gave providers some certainty. So that's the kind of broad stance. But I think I just want to take it the next sort of 3 weeks, really, just to see exactly where things are, and then we can take it from there. So.
Thank you. And I wanted to set my earlier question in context, really, to say, although there's a percentage of activity, we're clearly amending our approach and using our data in the background. And there's been a huge increase in terms of patients and families providing information through Give Feedback on Care as well. So it's clear that we're doing the best job we can in the circumstances. So well done to you and the team.
Thank you. That's absolutely true. I mean, I think it's one of the point that Chris made earlier on around give feedback on care. I think, and the particularly big increase in the primary medical services area is predominantly about lack of access to GPs, which is not a huge surprise on one level, but it does give us some sort of quantitative information, I guess, to drive some of our thinking, which is why we were intending to do some GP access inspections to try and get a sense of the sorts of things that were going on. And I think, Rosie has got a few days of that, and has already got some really important information. If we can keep building out those sorts of things to gather that really powerful information, I think it'll be helpful. I think our overall ambition here is to be as helpful as we can be, and in terms of the system, but at the same time make sure that we're being true to our purpose for the public as well.
Sally, I had exactly the same thought when I read the papers as you did about the 14%, and had I not been distracted over the weekend by other things, I was going to try and talk to Chris. So I'll do it now, Chris. I think it'd be really helpful if we could get a bit of segmentation on this number, because I suspect it's actually quite a substantial understatement. I mean, it just, for example, Kate, I know that you talk to corporate social care providers. So one conversation might well be covering, 50 or 60 registrants. So I think I'd like to unpick the numbers a bit and see where we are having that contact and where the gaps are, and perhaps we can bring that back to a future board meeting.
Yeah, that's no problem. Just say we are following up on that with Stuart based on the comments from the last board meeting. So we are looking at that and how we can incorporate that analysis.
Perfect, thank you. And Tyson's about to give us the answer. Tyson.
I was just going to say we are having a look as part of our planning for next year and for a new business plan. We're looking at all of our KPIs, including the one on regulatory contact, to make sure that it properly captures what we're doing. Sally's absolutely right about the increase in giving feedback on care, which I think has absorbed the time of a lot of the inspection teams. And I think I've talked at previous board meetings about the work that we've been doing to increase capacity so that we can spread our regulatory contact even wider, and that includes making more use of bank inspectors, which is being successful, and also the project to see if we can transfer some of the inquiries work to the National Customer Service Centre in Newcastle, so that we can allow our inspection teams to focus on the core activities that are really important to us.
Thanks, Tyson. While you've got the floor, do you have other updates you want to give, or have you covered that ground now?
No, I think I've covered it, Peter. I think things have moved on since my written update. And I've covered what I was going to say earlier. Thank you.
Thank you very much indeed. Rosie.
Just to add to Sally's question, that fit doesn't cover a lot of the informal work we do that gives us oversight of what happens in our providers we regulate. For example, in PMS, we spend a lot of time regularly engaging with clinical commissioning groups and sharing information that helps us identify where there's concerns and risk as well, which it doesn't get captured in that 14%.
Great, thanks, Rosie. So I think it's a bit of work to unpick that. Thank you, Sally, for raising it. Mark's not here. Ian, is there anything you wanted to say on cyber or anything that was in Mark's report, or are we okay?
I think we're okay. Thanks, Peter. I think, yes, I don't think there's any cyber incidents I want to raise in public. Thank you.
Okay, thank you very much. Chris Day.
Just three quick points from me. First, just on the bill, and just to build on what Ian was saying earlier, it has its first reading, the first debate at the Lords on the 7th. Peers were very supportive of our plans on local authority and ICS roles, and they were very supportive of the position on that from right across the House, and that was quite useful. The Lords Committee stage will commence on 11th of January. We're not so far aware of any amendments that the government intend to make, or indeed of their exception of any other amendments in the bill. So we'll continue to make sure that we can respond to queries from the bill team over the Christmas period, which is when some of those rise. And anything that we do, but obviously we'll make sure we'll talk to colleagues on the board so that we're aware of any changes in stance. But we're not expecting any at this stage. The second thing to say, building on the conversation that Chris Usher mentioned before, we're launching the next phase of our Because We All Care campaign, which links to give feedback on care. As colleagues will know, we've been targeting particular groups that we are hearing from slightly less to make sure that we can get everybody's experience of care throughout the year. So the next phase of this work begins on the 12th of January, targeting particularly carers, people with long-term conditions, over 55s, and people with learning disability, autistic people, and you'll see spikes of this campaign throughout the year, and it's been a really useful way of as Sally said, of getting additional feedback that help target our responsive inspections to care. And I won't go through the figures again, but the really strong figures and increase that we've seen. What can I also just take the opportunity to thank all the partners who've engaged in this work, particularly Healthwatch, who are a strong partner in our Give Feedback on Care work. But there are many other national organisations as well that provide support to this. But I think it's that collective endeavour to guide and to ensure that we can reach people, to get their feedback, to guide our responsive inspections is vital. The last thing I want to say, just it sort of builds on the conversation we've been having earlier. We've although we've paused much of our regulatory activity in secondary care, we've actually been invited in by some organisations to provide support to help them understand why people are accessing urgent emergency care in the way that they are. So there are a number of organisations that have asked us to support them in some research around how people and why people are accessing A&E in a way that they are. So that research is ongoing at the moment. It will report in the new year, and that links some of the work we did earlier on primary care access. I think will be helpful for the longer term debate about why people access care in the way that they do, and how we can support better either service provision or changes to the way people access care, so that we can move out of this particularly difficult point that we are at the moment into an area where we can improve services with providers and with local systems. And that was me.
Which neatly segues us on to the next agenda item, Chris. Thank you very much indeed, which is urgent and emergency care. Ian.
Thanks, Peter. We wanted to include this item on the agenda because we wanted to just lodge with the board our broader concerns around urgent and emergency care. And I completely understand the current and immediate context, but it was something that we raised in State of Care, and we felt now would be a good time to just refresh what we're seeing with the board, so that you're aware of what we're seeing. But I'll hand over to Rosie, Ted, and Kate in a minute just to talk about each of their sectors. But before we did that, I just wanted to set a little bit of context. And I think the obvious point is the context is incredibly complex. We think about at the moment, we think about COVID as being all-consuming. But I think if we cast our minds back to 2019, what we found was that the normal winter pressures of winter 2018-2019 actually rolled into the summer of 2019. So actually 2019 didn't have the normal peak, then the trough, then the peak that you would normally have in a typical calendar year. So 2019 was busy. The summer of 2019 was busy. We then rolled into a busy winter in 2020, and of course in January, February time of 2020, then COVID became a global challenge. And so what's happened is there's an overall demand, overall high demand, but alongside that, the overall productivity in the health system, and I stress health system in particular, has fallen because of the COVID safety measures. So when we talk to colleagues in NHS England, they quite rightly say, well, look, in order to create social distancing, we physically had to take beds out of some spaces. Many GPs have struggled with being able to see people in their surgery, just because it was never designed for straightforward social distancing. So I think there's a very practical productivity challenge around space. We also, when we talk to frontline professionals, they talk about the taking on and taking off of PPE being something which takes a couple of minutes a patient, but it's a couple of minutes a patient times 20 or 30 patients, and those sorts of numbers start to add up in terms of corroding the productivity of the system. When we look at adult social care, I think that the rebalancing of the economy that's taken place, particularly over the last 6 months has meant that people are leaving the adult social care system even faster than they perhaps once were, and sectors like hospitality, sectors like logistics, and in some parts of retail are also drawing people away from traditional social care roles, and that again has created just a very basic challenge around reduced capacity in the social care system. So you add all of this together, and I think, and what you get is a system problem that manifests itself particularly in urgent and emergency care. And we talked about a lot of these things in state of care earlier on this year, and things have got, things have continued to be as bad as they were, if not arguably worse than they were when we spoke about it back in October. So we go into winter 2021 under even more pressure, with the emergence of a rapidly spreading new variant in the form of Omicron. And I think people understand that is very transmissible. I think the deadliness or the hospitalizations is still not completely clear, but I think as I saw one of the newsreaders quite effortlessly put it yesterday, a small percentage of a very big number is still a very big number, and so I think I think everybody is concerned about the impact of Omicron. I think that the media will talk about lots of individual numbers, individual performance numbers, whether that be around GP access, whether that's in waiting times in accidents and emergency departments, or the knock-on effect of waiting times for ambulances and unloading times and things. Various points have been identified in the urgent and emergency care pathway, but I think we feel very strongly that health and social care is a tightly interconnected system, and pressure in one service is rarely a result of things which can be fixed in that service, that hospital, or indeed that GP surgery alone. And what we found is those places that have coped a little better are places where they've been able to maximize all the resources in their area, whether they be public, private, or indeed the voluntary sector, which I think is an area that really has a part to play here. Those areas have coped slightly better. However, I don't think any of us should be under any illusion that all services are under extreme pressure at the moment, and there is no easy fix, and we're not pretending that there is. But we thought it was important to talk to the board around the specific impacts in specific sectors and how they may plug together. So if I kick off with Rosie, and then Ted, and then Kate, and then we'll finish off with Chris, just talking about some of his perspective from some of the leaders that he's spoken to. Rosie.
Thank you very much, Ian. And just to give you a flavour of what's happening in particularly in general practice and urgent care centres. So the vast majority of urgent and emergency care actually happens outside of hospital walls, and the community response to urgent and emergency care is a vital part of the urgent and emergency care pathway. What we're hearing from providers, practices, and also GP practices, and also urgent emergency care centres, 111 providers, out of hours providers, is unrelenting demand, which has been going on for weeks now, into services. And I think some of this is driven by the backlog created by the pandemic. Some of it, however, it predates. We've known for a long time that the number of people with long-term conditions is escalating. The number of people with complex problems has increased, and that there is a need for new models of care to be able to deal with this and support people in a different way with these complex conditions and multiple long-term conditions. I think one of the problems we have in primary care is that we don't have the same level of data that we do in some parts of the rest of the system. So we don't truly understand what that backlog looks like in primary care and the impact that that's happening. And also we don't have the same level of demand figures. But I know I'm speaking to GPs regularly who are seeing daily numbers of people that they do not feel is safe to manage in their capacity, and that is a regular occurrence. And I think this is all on the background of a very tired, exhausted workforce and significant recruitment and retention problems. I think my main concern is the impact that this is going to have on vulnerable people and people who probably find it more difficult to access services for a whole variety of reasons. And I think we need to be working and encouraging systems to really understand how all providers in their systems are identifying those most at risk of inequality and the most vulnerable, and putting in specific ways of making sure that they get the care that they need. I think longer term, we need to really shift the system in terms of having much more of a focus on prevention, on early intervention, on things like advanced care planning. So we work in partnership with people to understand where they would like their treatment, where their goals are. And I think the other thing I would mention is I think we would also ask the public to do everything that they can to keep themselves well. So getting a booster, as we've talked about earlier, is incredibly important. Using if you feel you have something that can be managed in somewhere like a pharmacy, if you go and get some advice from them, if you have toothache, try and go and see a dentist rather than turning up at A&E. Let's see how we can make sure that we use all of the resources across local systems. I think the final thing I just would like to say is that this is so important that each and every part of the system recognises the huge pressures that everyone is facing at the moment, and it's vitally important that everyone in local areas works together to be able to address these. It's not one part of the system's fault or another. It's very much a problem that systems have to face together and have to come up with solutions. I suspect the challenges are going to increase over the next few weeks, and that collaborative working is going to be more important than ever. Thank you. I'll hand over to Ted.
Thank you, Rosie. And just to second all you've said, this is a severe problem facing the whole system. And it's a problem that we've been talking about, not just in the last state of care, but in previous state of cares. And the board will remember that we've been highlighting our increasing concerns about the urgent emergency care system over this winter, with the prospect of this being a very difficult winter, and so it is proving to be. The latest data that came out from NHS England last week shows that the whole system is still under intense pressure, with increasing numbers of people waiting for 12 hours to be admitted from emergency departments into hospitals, for instance. And just to remind the board, those 12 hours after a decision to admit has been made, a single patient may well have been waiting for many hours in an ambulance outside the ED, and then many hours in the ED before that decision to admit is made. So this means that people are often delayed getting into hospital by very prolonged periods indeed. And we are seeing that some of those people are really at risk of significant harm because of that delay, despite the best endeavours of the services looking after them. And I should say this is a reflection of the pressures on the system as much as the ability of individual services to provide care, because they are under intense pressure indeed. Many hospitals that we speak to say they've got large numbers of patients ready to go home who can't be discharged. And that is the issue here. This is an issue of flow through the system. Rosie's been talking about community and primary medical services. It comes into ambulance services, into hospitals, and then out of hospitals into the community and social care again. And we need that flow through the system so that people are getting the care they need in the right place at the right time. At the moment, the system is not delivering that. We've been doing some inspections, as I discussed earlier on. We've postponed them now until for a few weeks. But the early results from those inspections of emergency care systems have shown, as Rosie talked about, the fact that systems aren't necessarily working together well. And there's been a lack of coordination between different parts of the system. And really, we need, in the short term, in the immediate term, systems need to come together and work together really effectively to deliver this flow. and increase capacity wherever they can in the system so that the flow can be maintained. What we've seen and what we on our inspections, and this is supported by what we've heard from our specialist advisors who are in emergency departments all over the country, is that people are suffering avoidable harm from delays of ambulance handovers because they are held in ambulances for too long. They're suffering avoidable harm in corridors, in overcrowded emergency departments where they can't get the care they need. And I've been talking to staff who are really very distressed about some of the care they're having to provide in corridors to really very severely ill people. And also people waiting on trolleys to be admitted to hospital, often very frail, and they suffer harm from just waiting on trolleys. And we've seen patients coming into hospital and getting severe pressure ulcers while they're waiting in the emergency department. And for a frail elderly person to get a severe pressure ulcer is a devastating complication. So this is what is happening to people at the moment in the system. And there is risk throughout the system. There's risk in the ambulance service because they are being held in hospitals and cannot go out and respond to 999 calls. I've talked about the risk in ambulance delays and emergency delays, and there's of course a risk in patients who are held in hospital too long. As we've described before, if you're frail and need to get out of hospital, staying in hospital means a further deterioration in your clinical condition. And so holding people in hospital is not a safe thing to do. It's not good for the system. It's not good for the individual patients. And can I just speak about the workforce? Because talking to the workforce, and I've been talking to people at the front line in emergency departments this week, they are really under intense pressure. And I think we need to reflect on the distress they are feeling in their inability to provide the care they want to provide at the level they want to provide it. It is having an impact on them. And of course, workforce is going to be one of the key challenges as we go into winter, because not only are there current workforce shortages, they may well be exacerbated by Omicron and need for people to self-isolate. And I think this is a real worry going into winter. As we go into winter, Omicron may generate more activity on an already fragile system, but also it may take staff away from the front line where they're most needed. And I think those are the reasons why the booster program is so important. One thing that staff do want is people to recognise the pressure they're under and the problems they face in providing safe care. I think it is really important that we're honest with staff about what we can see in terms of the pressures in the system, and they can feel that they're not being expected to do things which they know are impossible to achieve. I think everyone's got to recognise that the staff need support, both in terms of moral support, but also anything we can do to improve the flow through the system. Now, we said earlier on that we've talked about this in State of Care. We called in State of Care for new models of care around emergency care. Rosie's talked about that already. It is absolutely critical once we're through this winter that we face up to the need to build an emergency care system that can provide the needs for the population as it is now, not as it was 20 years ago. And I think there's a real opportunity to build on this really difficult time to bring about the changes necessary in the emergency care system. And that is absolutely essential going forward. Thank you, Peter. I'll hand back to Ian.
So, Ted, just before we go back to Ian, I just want to pick up on what you've just been saying, because I think this is really, really important. We would have had exactly the same conversation in the winter of 2019. It's just that this is all now at an order of magnitude that much greater because of COVID, but the pressures were all there in 2019. They were there in 2018, and this winter we're in the middle of this winter now. We'll just have to tactically respond as best as possible. But there really does need to be a very big effort to do exactly what you've just been saying, so that next winter we start to see some improvement in this immensely complicated but vitally important piece of the jigsaw. And I just hope we start that work really early. I say we, I mean, it's not actually CQC that starts the work, but the work is started really almost immediately, because despite the pressures, the thinking needs to be done and the actions need to be put in place.
Yes, Peter, just come back at that. 2019, you remember, we described as the worst ever winter in the NHS, and that was before COVID hit. We are
Yes.
seeing the situation now is even worse. Last winter, to some extent, was exceptional because of lockdowns, etc. But we always knew that the winter coming out of the pandemic would be difficult. We didn't predict Omicron, but there are always winter viruses. So, you know, it's not as though we can't predict that there are going to be viruses that exacerbate demand in winter. And it's always likely that one of those is going to be COVID or COVID variant. So the situation we're in is not a surprise, quite honestly. It is something that's been predicted, and I think we do need to face up to the fact that we have, as a whole system, not brought about the changes in emergency care we needed to do. And if we had done that, I think we'd be in a much better place to face up to the challenges of the COVID pandemic. And I think that is a lost opportunity. And as you say, we were talking about this many years previously, and I think it really is important we do face up to that now and do the work to actually create an emergency care system that, you know, is not necessarily perfect, but at least has the resilience to deal with a normal winter and that extra capacity to deal with surges in demand driven by respiratory viruses.
Yeah, thank you. Ian.
So before we finish off, can I just bring in Kate and Chris very briefly, because I think you're right. This isn't a problem that we alone can solve as CQC, but I do think the perspective that we bring, particularly the perspective around adult social care and that integration of services together, is very powerful in terms of painting the picture around what good might look like. So can I just bring in Kate and then Chris, and then perhaps open up for further conversation?
Thanks, Ian. So echo a lot of Rosie and Ted's comments. I think for me it's critical that when organisations are under pressure, they don't revert to just thinking about their bit of the pathway, their bit of the system, that they continue to think about hospital avoidance, timely discharge, etc. So from a social care perspective onto the urgent and emergency care agenda, I think it's important to remember in our state of care report, we talked about discharge to assess, and we talked about when discharge to assess is done well, people don't make long-term care decisions from an acute hospital bed, but they're supported to leave hospital in a timely way when they're medically fit to do so, have reablement, rehabilitation as and when needed, and then their long-term care needs are decided. So I just want to ask for us to all remember the benefits of discharge to assess when it's worked well. And in state of care, we called for a longer-term commitment around discharge to assess to enable that long-term planning. A couple of things on social care. There is physical bed capacity in the residential and nursing market. There's physical bed capacity where maybe the issue is more about workforce to staff those beds, but there is physical bed capacity out there in the residential and nursing market. What might a system response be to using those physical beds that would take someone out of hospital, put them somewhere where they'd be safe, either as a short-term or a long-term solution, but there would need to be a system response to look at the workforce piece. I want to flag destination settings. So this was stood up last year where people who had a confirmed COVID case whose long-term destination was a care home, either returning to their usual place of residence or being discharged there for the first time. If they had COVID, across the country, designation settings were stood up in a number of adult social care providers, but also in some community health provision as well. Those numbers have reduced. I think it's really important that systems think about what their need is for the designation settings, either in residential nursing homes or in community provision, pretty urgently as we go into this winter, as I would suggest that the need for them might increase as we start to see the kind of impact of Omicron. And then the final thing is we know that there will be a significant number of people in hospital ready to leave who'll be waiting for a wealth of things. But one of those things they'll be waiting for is home care. And we know that there are particular pressures with the workforce challenge in home care. Government announced 162.5 million for the social care workforce, followed by a 300 million. As a system, how are we all collectively making efforts to ensure that that money passports through as quickly as possible to those home care workers in whatever form that might look like, that ensures that that home care worker doesn't decide to leave their really tough job, tough but essential job in home care now to go get a job in retail over Christmas, and that they stay doing the invaluable job in the part of the system we need them to be doing so. So just for me, a real plea that under this immense pressure, system leaders still think about what is needed from a system perspective, because in the end that's the best thing for people and patients, but also it means that things will work a lot better for people as they as they move through. Thank you.
And Kate, the really important thing about home care is not, it's obviously important about when it comes to being able to discharge people back to their homes. But if home care is not there, we're going to see an increase in admissions coming back to something that sort of Ted was touching on. So to me, home care is probably one of the most important things right now.
So this kind of, as you say, Peter, is both ends of the pathway. So it's about when people have care needs, they get assessed in a timely way, and then they get that package of support arranged for them in a timely way. And then should they need a hospital admission, there is then the social and the community services for them to be discharged out of a hospital bed when they're medically fit to do so into their long-term kind of destination.
Yeah. Robert.
Thank you. Well, firstly, endorsing everything that's been said by Kate and colleagues, but a feeling of being profoundly depressed because I've now been listening to this conversation and this description of these problems on this board for far too long. I mean, ever since I've been on it. And that's no criticism of anyone who's here or their predecessors. But let no one pretend that this is an issue that comes about because of the pandemic. It was there before, but it's now been exacerbated. What has changed, I think, is that perhaps in the early days, it was thought or suggested, perhaps rightly, that actually in a well-run, well-led place, this sort of thing didn't need to happen. So our outstanding hospitals, for instance, didn't have the problem that our less adequate ones did. I think we're now in a situation where, however outstanding a place a provider may be, this is a problem. Because it's not a problem just in relation to those in hospital who shouldn't be there. It's in relation to all those who are not suffering from pandemic-related diseases, but other things, who are increasingly not getting treatment and in many cases increasingly becoming more ill. So my concern is that really we need a recognition currently that we should be on a war footing, and we're nearly more looking like that. But I think there has to be a more honest conversation in the system about, in the very short term, about what it is that we can't do and what we're doing about it. And we cannot, I suspect, any longer claim, or shortly we won't be able to any longer claim, that the NHS is performing its function of delivering free care at the point of delivery to all who need it. It's just not on what is being described doing that. So what do we then have to talk about? We have to talk about priorities. And I'm not sure we're having an honest conversation about that either. For the medium term and the long term, obviously we need to change the system. We need a systemic approach. And you've described how that should happen. Just one minor point, but perhaps an important point about how can anyone help now. And I just wonder whether we have sufficiently explored, I said we generally have sufficiently explored the use of volunteers. We're using them to great effect, I think, in the vaccination programme. There are many wonderful volunteers in our hospital services, but I just wonder whether there's greater scope, bearing in mind I know that many members of the public are willing to do their bit, where they could be used more to relieve our hardworking hospital and our NHS staff generally to do the jobs they're really qualified to do.
Chris. You may not be able to answer Robert's points, but
well, no, I can. I think just to go back to something Ian said that was important. What we do provide is an overview of perspective, and we've been having some really good conversations with different parts of the system about this response. The urgent emergency care we are talking about is obviously a wider system issue. It isn't just about emergency care; it is about the wider system issues. And in the sense that there are, when you're talking to sort of some of the NHS trusts about this, they describe it as moving people out of hospitals, control of skin. But then there's a wider bit about controlling of access, which comes to Robert's point. But just to talk about movement out and to go back to what we said earlier, the reason why we want to prioritise RI to good inspections in adult social care is precisely to improve the capacity of the adult social care market so that we can help with some of the discharge arrangements from secondary care. But if you look at the Association of Care Homes report today, they are saying that there are still almost half of home care providers that are concerned about their long-term financial viability, which is why in State of Care we talked about the importance of making sure we had a viable home care sector that could support people to move out of hospital. The other issue that we're talking to with both NHS and community, acute and community trusts, is what's the relative risks that people are taking. So access to community care is also a challenge as well. How do we make sure the risks are being appropriately managed between those two sectors? In terms of control of risk I'm really grateful that the patient first work that we did much earlier in the year has at least given organisations a guide of how to manage and support. It's a great piece of work in Ted's team to help guide that work. What it does say, Robert, to your point, is that you can't manage urgent emergency care by looking at urgent emergency care alone. There is the relationship between not just the wider parts of the hospital, but the wider parts of the system are critical. And the last area about the control of access into hospitals, I mentioned before we were doing the working with some trusts around a survey of A&E service users to understand why they arrived at A&E. I think there's some really good examples in some of the ICS areas of how volunteers have been used to support some of the admission avoidance places. I think what we should do with each of these areas is to give a sense of what the opportunities are to move away from this crisis point for ICSs. So we should use our data and hopefully to give not just a national perspective, but a regional perspective, so that our information can be useful in the conversations with the ICSs about how they tackle the problems in their area. In that way, I think what we know nationally can help guide thinking both regionally and nationally.
Rosie.
Just to follow on from what Chris was saying, is that this is, we can't look at urgent emergency care in isolation, and it's not something that will be possible for this year, but we need a cultural shift in the health and care system from something that's very reactive to something that's much more proactive, that actually empowers people to manage their long-term conditions, which usually are the driver of unplanned care, and that actually supports people to make informed decisions that are going to both support their own outcomes, but then also support the pressures on urgent and emergency care by making sure that they get the care in the right place at the right time for them. And I think that we have significant opportunities when we're starting to look at our regulation of systems as we go forward to think and work out how, as a regulator, we can enable systems to consider these new models of care that are going to help to meet challenges going forward.
Thanks, Ted.
Yes, just to second what Rosie was just saying there. I remember a few minutes ago I was talking about the community mental health survey and the fact that we're not providing community mental health services, or providing access to people who need community mental health services means that they deteriorate, and many of those are turning up in A&E, and there has been a surge in people with mental health crises attending A&E over the last year, and that's been one of the things that's been driving the problems. But you can make the same about lots of other areas as well. It's not just mental health. I think we need to be much better at preventing people deteriorating so they don't end up in A&E just because of deterioration of a long-term condition, which is we see far too much of. But we also need to provide better care for people who are frail and elderly who actually don't. Going to hospital is not a good thing for them to do, but there are not sufficient alternative care available for them in the community or at home. We need to make sure they're looked after to be well, but also to be independent, not admitted to hospital, and by being admitted to hospital, institutionalized, so they'll never be independent again, which is what the system does at the moment. There are lots of other areas as well. So when we talk about new models of care for urgent emergency care, it is about finding new models of care for all these other challenges in the system. And one of the impacts of the problems in urgent emergency care is it's impacting on elective care. And of course, people are genuinely worried about getting the operations they need, not because they're an emergency, but because it's necessary for them to improve their health. And that is, we saw again last week that the elective care waiting list is now over 6 million, and this is going up still. But because urgent emergency care is competing for capacity on a daily basis with elective care, that inevitably will get worse over this winter because of the pressures of urgent emergency care. And that's because we don't have a model of care that protects elective care from this kind of distraction. So we've got to look at models of care across the whole system. But the priority is getting urgent emergency care improved. It won't be a 1 year's job. It's a long, complicated problem, but we need to be making progress in the right direction. And just to come back to something that Robert was saying, this is not just a problem of problem hospitals. This is a universal problem. Every place we speak to in the country is having this problem. It will vary, and some of the local issues in the local system will vary from one system to another, but nowhere is running a service that is actually the service we want to see for people requiring this kind of care as yet.
So I suspect we could spend the rest of the day talking about this, because it's such an important topic, and we've all got different aspects of experience. But I am mindful of the time. Ian, is there anything you need to say in way of sort of to wrap this up before we move on?
No, thanks, Peter. There was no intention to arrive at a specific action here, other than just I think to share with board our overall concern, and this narrative, if you will, this conversation we've just had is something which informs our day-to-day interactions with a range of different system partners, whether that's NHS England or the department and so forth. So we're constantly using this backstory, as it were, to try and influence and talk to other system partners to make change happen. But as we've just said, it's a very tough environment in which to significantly change. One would argue we should have done this years ago, but I think we are where we are. So thank you.
Yeah, absolutely. So that takes us to the board effectiveness review, and Rad, you might want to add a postscript now to the board effectiveness report, saying that the chairman can't manage meetings to time, because we are running very late. But I think we had some really important discussions, which I certainly didn't want to cut off. So can I just hand over to you to introduce your report, please?
How long would you like me to speak
for? As long as you are. I don't want. This is also important, so okay. We're not going to cut things off just because we're running late.
Thank you. So, well, thank you for letting me listen to the rest of the meeting, which was humbling, actually, and a kind of privilege to listen to some of the challenges that you're thinking about. I want to just set a wider frame before we dig into CQC's governance, and just recognise that across sectors, private sector, public sector, not-for-profits, there's a homogeneity of what we now consider good governance, and that's influenced by cross-fertilisation of different codes and checklists, and of course consultants like me. So in a way, the kind of tenets of good governance, things around the clarity of roles and responsibilities, processes around board effectiveness, committee structures, risk management, all of those, there's a commonality of expectations across different codes, across different sectors. There are some areas where things like the global financial crisis, for example, in 2008, have an impact on governance. So risk and assurance has become much more important since that time. That time also sort of started to influence governance thinking about culture, because there was a sort of exploration of the culture in banks and financial institutions. And of course, events of the last couple of years, things like George Floyd's murder, have also influenced some of the debates in governance around diversity and inclusion, and thinking more widely about organisational culture. So all of that is to say that governance doesn't exist in a little bubble of its own. It's reflecting what's going on in the external world. It's reflecting the growth in new technologies, social and economic movements, climate change, socioeconomic drivers. And so in a way, it's not a static thing, I suppose, is what I want to say. There's a commonality of tenets of good governance, but there are other things which shift. So it's a dynamic set of arrangements and relationships. And in a way, I would say that good governance is always about the pursuit of better, that it's somehow slightly restless. There will also be matters of context for any organisation, and of course those play into your context too. So the areas that we focus on for improvement in these kinds of reviews, of course, reflect those wider things about the tenets of good governance. So pretty much any report, I will be making recommendations about, board effectiveness, or about committee structures, or about the conduct of board business. So the fact that your report has some areas of focus related to those things is normal. So that's what I wanted to sort of preface, really. That we've engaged in a wide variety of methods, because many of you have been involved with them, document reviews, surveys, interviews, focus groups with staff, meeting observations. So our findings are really, some of them are about you holding up a mirror to yourselves, and some of them are about our interpretations of where you are. And I would say we've found a foundation of really good functional governance, a really capable and strong board and executive team, and it's really clear that your governance and leadership, and I would say from an external viewpoint, your reputation is in a very different place to where it was 10 years ago. And I think that's testament to the hard work of the chair, the previous CEO, the current CEO, and I'm sure an array of different sort of board members. So there's been a lot of hard work over the last decade, and I want to just recognise that at the outset. And I think I've met an organisation that has a huge commitment to openness and transparency. The fact that we're having this conversation in a public board meeting, I think, is testament to that, and is probably pretty unusual. I'm not sure that with other regulators I've worked with that they would have this conversation in a public board meeting. So you know, I think that's something for members of the public to be aware of. I think the governance challenges for you now are different to what they were 10 years ago, of course, and I think the next era and the next phase for you as an organisation are challenges that the next chair will probably have to pick up, whenever he or she is appointed by the Department of Health and Social Care. And some of our recommendations are about cultural choices. So there are always cultural choices about how a board and an executive work well together. So there will be some things around good governance that we recommend, and then there are things where we recognise where you are and how you might want to change, and we make suggestions about choices for you. There are some matters of context that I want to draw out that influence our thinking about where you are. The board has had a clutch of new arrivals all at once, and you probably wouldn't have designed it in that way, but that means a bit of digesting, I think, of new people, new personalities. Of course, the dynamics change a bit, and they are getting to know the organisation, which is complicated by the fact that we're living with a pandemic, and they will also bring fresh eyes to some of the discussions and conversations. So both of those things are in play. I think COVID and the conditions of remote working also create challenges for boards. All boards will feel that the absence of in-person meetings is something suboptimal, and of course that's come through in the review with our interviews with you. So a board with regulatory responsibilities and with new arrivals, it will feel doubly frustrating not to be able to get out into the field in some way, and for you not to be not able to get out of the boardroom. I think getting out of the boardroom really helps to understand an organisation, helps you engage in reality checking. It also helps you engage in some liminal spaces that I think help provoke wider thinking about the organisation and its purpose and how you're delivering that. So I recognise that that's a huge sort of subtraction in a way that you're trying to work against. And I think some of the richness, the fluid interaction, building on each other's conversations, it's a lot harder to do that in a virtual environment. And pretty much every board that we've worked with has said that. CQC is working on its approach to regulation. There's a huge transformation programme underway. These kinds of programmes, they're always challenges for boards to get to grips with. The fact that you're wrestling to get to grips with it is normal, I think. And the needs of a board may change over time in any case. So what you may have needed in relation to the programme 1 year ago, 18 months ago, may be different to what you may need over the next 12 months. So this exciting, challenging work is going to bring systemic change to you. It will be a hugely important step change for CQC. And I think it's not surprising that you're thinking about how do we oversee that well. So that is always a challenge. The transformation programmes, how boards interact with those. I think I would expect that to come out of a review like this. Lastly, a matter for focus in any review is about how clever people are using their time well. And I know from interviewing many of you and my colleagues doing the same, you know, there is a very clever, competent group of people in the board and in the executive. And for me, the challenge is, you know, how do we get the best out of all of you? Is that delivering the best outcomes for CQC, and through that, the best outcomes for the public? And I think some of the things that we're trying to prod you towards are about trying to make sure that you really optimize the use of your time together. So the organisation is embarked on these really important future-facing changes against this very challenging environment that we've just been hearing about. And I think it's important that governance moves in alignment with that change, that you have space to be proactive, a little bit agile. Remote working in some ways has helped boards be more agile, and that you look for opportunities to work differently and efficiently. And I think that is the space that I'm trying to invite you in, I think. I've identified a cluster of themes or considerations, and I think they're about moving you along this sort of good to great journey. So some things around board effectiveness. The new chair will have to develop cohesion in the new team, and I think it's good practice anyway for boards and executive teams from time to time to step off the treadmill of your board business and look at how you work and see whether you can work differently. And I think that helps to build trust and build thinking. There are some other small suggestions about ways of tightening up aspects of board effectiveness. A second thing is about the conduct of board business. We sometimes talk about boards having an oversight role, a strategic and tactical role, and an insight or sense-making role that we sometimes call generative governance as well. I think it's helpful to think about when you're in those different modes of governance, because behaviours can be associated with those different modes. And we think that board time could be better organised to allow more opportunities for that kind of generative thinking, for board members to bring value through applying their insight. And that would mean something of a reset to some of your meetings, agendas and content. And I think that space has felt a little bit constrained in recent months. A third cluster of themes is around performance, risk and assurance. I think it really helps if the strategy, the risk appetite, the performance reporting, the risk and assurance frameworks feel properly integrated. And I think you're still on that journey. The fourth point is around committees. It will depend on some of the other recommendations that you pursue. But were you progressing the work around assurance? I think there are opportunities to think about the committee structure in a slightly different way. And that could help support finding discussion spaces around your emerging approach to regulation. And then lastly, I think there's scope to think about how governance support is strongly steered. So it's someone's responsibility to really look ahead and be accountable for the design of the board work. And I know that that's probably a challenge around resources as well. So lastly, I wanted to just put on record my thanks for the openness and collaboration that I've met with from CQC. I particularly like to record my thanks to the chair, to Laura Ottery and to Naomi Patterson, who have all helped in the conduct of this review. And also to emphasise that it's an independent report. There's no fettering of the expression of our views as Campbell to Kell, and I'm very grateful for that.
So I think we're very grateful for the report. I think it's a massive amount of food for thought in there. So thank you. Well, what I'm suggesting, colleagues, is that we don't discuss how we're going to respond to individual points or anything like that today. I think, as Radu suggested, this is really quite a long conversation that you as a board need to have with your new chair. And certainly the last time we had a board effectiveness review, we had a couple of seminar sessions to get our minds around how we wanted to respond, and then brought those responses back to the board. And I would recommend that's the right approach for the future. And you very kindly said that you were happy to come and lead or contribute to one of those sessions. I thought we timed this brilliantly. I thought this was going to be my last board meeting, so we just sort of hear a whole load of problems and then seamlessly next month there'd be a new chair and it would just carry on. Hasn't quite worked like that. So it may be, I mean, who knows, there may be a month or two's delay, but that doesn't mean that the points go away. They're just as important, but I think it's right that we wait. So for now, today, I just want to say, if there are points of sort of clarification that people want to ask, so that they can go away and think about the report in advance of the seminar sessions, please ask them now. And excuse me, choking away. If not, I think the report is very clear, and I'd like to suggest that we just receive it and it comes back to the board. Excuse me. Once the new chair is in place. Anybody want to raise anything right now? Perfect. So once again, a really good report. Lots of food for thought. Oh, I was too quick. Taflik, did you want to come in, or was that your hand's gone up and down?
Oh yes, Chair. Sorry, I've just posted something in the chat. I'm not pretty sure whether you've seen it.
No.
Oh, okay. So I've just asked if I'd like to know if we have a forward succession planning in place for planned and the unexpected.
So, sorry, I didn't quite hear the last bit. Forward plan for what? Sorry.
Forward succession planning in place for the planned and unexpected.
So
for the board, for the composition of the board.
The composition of the board is only partially in our control. So all the non-executives and the chair are appointed by the Secretary of State, not by us. So we do input to the Secretary of State what skills we think we need on the board, and as a retiring member goes, how do we need to what skills do we need to replace to avoid having a skills gap. So that process goes on, but we're not able to directly say, and therefore we will appoint X, Y, or Z. In terms of the executive directors who are appointed by us, then absolutely there is a clear plan for appointing successors to people as they retire or move to greater things. Does that answer your question? Okay.
Yes, Chair. Thank you.
Okay. No, thank you very much indeed. Can I just suggest that we if everybody's happy, we receive the report. We thank you very much for it, because I do think it's a very good report. And then it will come back to the board with your new chair sometime, hopefully fairly early next year. Okay, and then if we can move on to the Equality Networks update. And invite the other Equality Network people are going to join us to come into the meeting. One of the recommendations or one of the suggestions that is in your board effectiveness report is that we allow the network representative to talk a bit about their network, and actually that's what we do in the session that's about to start. And we had originally terribly cleverly planned this so that we would have this session and then we would all go to lunch together. An informal conversation with the networks could carry on over lunch. Unfortunately, that part of the plan hasn't worked quite as I hoped, but we may have another opportunity in a few months to get you all back. So let's sort of 5 minutes each, if I can sort of put a reasonable expectation on it. And I don't know whether you've agreed an order between you, but if not, since you're already in the hot seat, Tefik, do you want to start?
Thank you very much, Chair.
Sorry, could I just interrupt? I think Jill was just going to do a bit of an introduction, but
yeah, I just wanted to, Peter, if I may, I just wanted to say a few words and by way of introduction. I won't take too much time at all, and we've got the colleagues that are here from the networks have prepared sort of their piece to talk to you about around their slides, but I really wanted to just preface that with saying that this is the session that allow us to hear about the really great work of the networks, and also an opportunity for us to reflect on what we want to take into the new year and how we want to continue with working with board colleagues. it's really important, I think, also to recognise the role that the networks have all played in supporting colleagues across the organisation. This year in particular has been challenging, and the networks have been integral in this space, as well as delivering, as you'll hear about shortly, a vast array of events, learning and engagement sessions across the organisation across the year. And I wanted to add my personal thanks to the chairs for all they have done over the past year, as well as the many co-chairs and deputies that have also helped in this really important space. So I won't say any more because we're short on time, and it's not me you want to hear from, it's from colleagues on the call. So I'll hand over briefly to Felix, who's just I think is also going to run us through the slides on behalf of colleagues.
Yeah, so my name is Felix Petru. Nice to meet everyone. I'm an organisational development advisor, and I'm also the chair for the Joint Network Voice. So for those who don't know what the Joint Network Voice is, it's a meeting that happens once a month. And it's where the 5 quality network chairs and vice chairs join to feedback on work which is happening across the organisation. So they've also contributed to things like the transformation of change, and they're able to comment on things like quality impact assessments and policies. Another thing I wanted to flag, which all the joint network do, is encourage the involvement of independent panel members from their networks, which is mandatory on grade A and executive recruitment panels. And then finally, they've also been really successful and engaged in the wider organisation through Ian's All Colleagues calls, which happen weekly, which we'll be hearing about after me. So I'm just going to hand over now to the Carers Equality Network, and they will be telling us about their biggest achievements this year.
Hi there, good afternoon. Julia Corrigan-Davis. I'm the co-chair of the Carers Equality Network at CQC. This year we've sort of continuously been building on a safe and welcoming forum for sharing experiences, offering advice and learning and support for our colleagues with caring responsibilities. We've done a lot of work to promote the Carers Equality Network. Our membership's increased by 23 members this year, so we're now just under 200. We introduced regular coffee catch-ups. They are sort of fortnightly or 3 weekly, where it's a safe half-an-hour space, just a time to chat, time to share, unload, and try to normalise our world. So, and that's sort of been really well received. We promoted Carers Week. We held a range of activities and signposting support. We had Carers UK come and speak to our members, and also Carers Rights Day, where we ran some promotions in conjunction with Carers UK. We've also established strong external links across the civil service and other organisations so that we can share best practice, promote the support options. We've done some benchmarking, reviewing policies and practice across different organisations. This has all accumulated in us applying for Carer Confident accreditation. I'm pleased to say, I think it was about a month ago, we were accredited with level 1, which is active level. And that actually means that CQC is an employer that actively recognises and supports colleagues with caring responsibilities, better enabling them to fulfil their work roles. The next level is accomplished, which will mean that we've nailed the active. So that's sort of basically it from me. The collective aim is to support each other and raise the challenges of combining a career and caring responsibilities, and also influencing our working policies to drive equality and inclusion across CQC.
Thank you, Julia. Paul?
Good afternoon, all. Yeah, my name's Paul Kirby. I'm the chair of the Disability Equality Network. We've had a tough year, a lot of challenges and changes, but we also had a positive year as well. So we have obviously a very successful subgroup in DEN, ranging from Dragon to neurodiversity. We provide a platform for personal stories for members to share their experience, so there's no isolation. There's other people are struggling or champion access and give good role models to other staff with disability. We campaign sort of accessibility, for example, the short email signature. There's one of our colleagues that had trouble with reading with the voice recognition of the email information on the signature. So we've actually reduced that across the CQC, which is successful. And the NTSC has started the process to require British Sign Language with Sign Live. So hopefully BSL users outside the organisation can contact the organisation, making it accessible. We have a quarterly DEN newsletter with our third one, which should be out next week. So for everybody to read, to know what's going on with DEN. We promoted the International Disability at Work Day on the 3rd of December. And we're in the middle of doing the event of Disability History Month from the 18th of November to the 18th of December. So if you have the opportunity to have a look at the recording of some of those presentations. We contributed heavily on the Workforce Disability Equality Standard. And what's really exciting, we have 50 new members this year. So that's one new member a week. So we're a growing group. We've done a great work on mental health and wellbeing workshop by the mental health subgroups. They've done great with Hannah Sutherland. She's done a great work on that and working with the wellbeing team. We also try to encourage disability and diversity of self-declaration on the ESR to show the increase of numbers of people with disability. And we promote support the use of tailored adjustment plan, accessible information standard, as well as access to work. So that's a lot of work that we're hoping to do in the new year. And we've contributed workshop training for managers. And the main key is promoting disability staff confidence and organisation status. So it's growing strength to strength, and I'm proud to see the group growing and contributing and taking responsibility of showcasing their disability across the organisation.
Thank you, Paul. Jasper?
Hi, I'm Jasper Jackson. I'm one of the co-chairs of the LGBT Plus Equality Network. So in terms of network changes over this past year, one significant one is we have had our elections for our network chairs. So outgoing, we had Beth Matthews and Felix Petru, who was of course on the call, and coming in as Becky Applewardine and myself. Alongside the chairs, we do have bi and trans reps who are supporting particularly marginalised segments of the LGBT plus community, and they act as points of contact for questions from CQC colleagues. Key events and achievements over this past year. We've been engaged with the induction process this past year, so we've been helping to ensure that new colleagues are introduced to the staff networks as part of the culture of the CQC, and they're aware about how they can engage with the network, what we can do to support them, and also what they can do to support us. We've collated some network responses to policy reviews by HR, and that includes prompting HR to prompt a previously completed review of the guidance for supporting managing staff who are transitioning while they work at the CQC. We've promoted, as Felix mentioned earlier, the Independent Panels Members Initiative, and we have a few members who are part of this initiative. We've created more social support services spaces for colleagues within the CQC instead of just being externally looking, and that includes worry spaces where people can talk about how they're affected by current events, how they're feeling, and a film and culture club to explore LGBT plus related media. And we'll be going to continue this over the next year with spaces to directly discuss LGBTQ related current events. We've put on significant programmes of talks for both LGBTQ History Month and Virtual Pride for the CQC, open to all colleagues here, and as well as colleagues at partner organisations, and these were to promote awareness and understanding of issues that face LGBT plus colleagues and service users today. This has included sessions with external organisations, including Hidayah, who are a charity who serve and support queer Muslims, and with Intersex Equality Rights UK, looking at the experience of intersex people in healthcare environments in the UK. In less good news, unfortunately, Ray Mason, who led on our Virtual Pride social media engagement, faced significant homophobic harassment and abuse on CQC channels by a vocal minority of internet users, including a wide variety of old and tired insults and misconceptions. But fortunately, the wider CQC worked well with Ray to support him and put out a strong message of support for our LGBT colleagues and people who use the services we regulate, including that, not because it's an achievement, because I think it's important to recognise that despite the wider support of LGBT plus people within society, there is still ongoing discrimination and abuse. Finally, we worked alongside organisational development on the submission to the Stonewall Top 100 Employers List 2021, which is a nationally recognised ranking that both helps us ensure that we as an organisation are supporting LGBTQ staff, but it also helps us ensure prospective colleagues that we are a safe and supportive place to work for all, which will obviously help us encourage the top talent to come and work at CQC. We're hoping to continue to achieve a good ranking, and we hope this year to get into the top 100 list for 2022. So that's all for me.
Thank you, Jasper. Taufik?
Thank you, Jasper. So we have Race Equality Network. Our executive sponsor is Kirsty Shaw, ably supported by Tasnim and Latoya. Our purpose: to promote and champion race equality and inclusion across CQC. To do this, we focus on key recommendations from Roger Klein's report, the REST report, Joint Network Venture, Black History Month, etc. The Race Equality Network is one of CQC's staff diversity network and is staff-led. Race Equality Network 2021. We held 12 talks events this year, part of which was the LGBT plus History Month, the vaccine hesitancy, owning your own career development, Black History Month. I'd like to thank the OD, our executive sponsor, Kirsty Shaw, which is Tasnim. A range of topics. I particularly enjoyed the David talk. I'm proud to be part of an organization that supports the types of discussions we've held and see members of our exec team joining and contributing to these discussions. We held a listening event in June to commemorate 1 year since the murder of George Floyd, and to follow up with all the brave colleagues who spoke up about their experiences of racism and inequality at work last year. This event was hugely impactful on us, and there was some really worrying feedback that came out of the word cloud we did on Mentimeter at the event. Most of the words posted by colleagues who attended the call on what it feels like to being a person from a Black and minority ethnic background at CQC, among others, were unchanged, disrespectful, engaged, ignored, degrading, drained, lonely, optimistic, static, excluded, tiring, soul-destroying, micromanaged, and positive, misunderstood, and the list goes on. Whilst we know colleagues are working hard to change the culture of the organization, I want to ask that you all become or continue to be visible, equality, and inclusion allies. I urge this board to approve full positive action under Section 158 of the Equality Act, providing targeted employment opportunities for colleagues who clearly have enormous untapped skill sets. So everyone, please join us and be part of this struggle. Thank you ever so much.
Thank you, Taufik. And now we're going to go to Lizzie.
Are you all right to reshare your slides?
You should be seeing it now.
So the aim of, so I'm Lizzie, and I'm one of the co-chairs of the Gender Equality Network. And the aim of our network is to improve the experience of women working at CQC, but also reduce the overall impact of gender inequality on all staff. Kate is our sponsor, and she's incredibly supportive. Some of our main priorities are providing a space for networking and peer-to-peer support across CQC. We've got around 130 members, and we've also had quite a lot of new members in the last year. We've particularly focused on having some networking and informal sessions over COVID, and brought over 100 people across CQC together to talk about the impact of COVID on flexible working and on being able to kind of juggle family life and of overall well-being. And we got a lot of good feedback that those sessions were really helpful. We also did an International Women's Day panel event that we received lots of great feedback for, and it had some really great speakers across health and care. And those women told their own leadership stories and talked about some of their own struggles in obtaining quite senior positions in healthcare. And we also looked at the role that networks can play in supporting women to gain leadership skills. One of the key pieces of feedback from the survey that we originally did was that women in general wanted more leadership support and training opportunities, and they really valued senior women from both inside the organisation and outside the organisation talking about their own journey. So that's something we've chosen to focus on and will continue to focus on. We also had the murder of Sarah Everard, which was incredibly distressing for a lot of colleagues, and we talked about that and how colleagues were feeling and the impact of that. We have had a couple of changes in the leadership. So Blessing, one of our colleagues, stepped down as co-chair, and one of the other colleagues left to get a promotion at the NMC. So we've got now 2 new co-chairs, one of which is Hannah Carson, who comes from working in Parliament, and she set up a parliamentary women's network there. And the other one is Diane Horsley. So in the new year, we're going to rerun our survey and recheck in with what the key priorities will be. That's all for me.
Thank you, Lizzie. So now we're just going to have a bit of a discussion time. So we have a question for the board and also the network chairs with us today, which is going into 2022, what are your recommendations on how the networks can make the most impact, and how can the networks continue to involve and work with board members in the new year?
So can I just first of all thank everybody for those presentations, and but more substantially, I think thank you for all the work that you do day in and day out in the networks. I think they're a really big part of CQC, and I'm really very pleased that we have these networks. As I said at the start, my clever plan was that we would go seamlessly from this session into lunch, and lots of individual discussions could then take place. That clearly isn't going to be possible, but I think partly to answer your question, it may be that some of my board colleagues want to talk to you offline, as it were, separately and outside the board, and as long as you're all okay with that, I'd be very pleased to see that happen. The other sort of general comment I'd make is that we are looking at the whole way the board works going forward. So one of the things will undoubtedly be, do we continue with the network attendances at the board? I sincerely hope the answer will be yes, and can we do that in a more meaningful way? So I think there's quite a lot of work to do. I'm not sure that we're going to have time today to really get properly into the exam question you set us, but having said that, various of my colleagues have put their hands up. So Ian, why don't you go first, and then Sally?
Thanks very much. I just echo Peter's thanks. The work that you do, sometimes it's quite public, sometimes it's quite quietly influential in the background in terms of giving us your take on particular issues is just hugely helpful. I think one of the things I'd be interested in exploring over 2022 is this issue of intersectionality, because I think all of you have spoken very eloquently about your particular areas, and I know from the conversations I've had with each of you separately that it is something that you're starting to think about. I think for 2022, I would be interested in how we can link the networks together, maybe, or how the networks can have a point of view on this issue of intersectionality, because I think we've made some great progress in a number of areas, but it feels that's kind of almost the obvious next step. But how we do it is, I think is quite complex, and certainly isn't a conversation for now, perhaps, but it'd be something I'd be really interested in for 2022. Thanks, Peter.
Thanks, Sally.
Yeah, thank you for the presentation, and I echo what Peter and Ian both said. For me, I've had more contact with the Disability Equality Network and less with the others. But actually, whilst your attendance is really welcome at board, it's also fantastic just to hear more today about what you've been doing. And I think for me in 2022, it'd be good not for you just to attend, but to come and talk to us, both about what your achievements are, but also what the board could do to help you make more progress. Thanks.
Thank you. And I think there is, if not exactly an open invitation from all the networks for us to attend them, there are opportunities. So as I said earlier, I think individual follow-up is good. Shall we, given the time, shall we leave it there? But I think there's a lot of discussion still to be had, so I don't want to pretend that's the end of it. But I think maybe the end for today. Thank you all very, very much for coming. Sorry we kept you waiting, and we will be talking to you again in the new year, I think. So thank you very much. That takes us to any other business, if anybody has any other business. And if there isn't any other business from the board, I'm going to slightly truncate the questions from the public because we are running so late. So we had two questions from Robin Pike, and Robin, I'm only going to take the first one today. Second one, perhaps you can bring back to a future board meeting. It doesn't particularly relate to anything on today's agenda. So your first question, which is, I think, very topical, is how can CQC ensure that visitors are allowed into care homes and hospitals subject to infection control requirements? How is access ensured in secure units? So, Kate, do you want to start us off on that one?
Yeah, happy to. Thanks, Peter, and thanks, Robin, for the question. So just a few comments on this because we've discussed it a number of times at board because it's such an important topic. So firstly, the majority of social care providers are doing what we need them to do, which is making every effort to follow the latest government guidance and to make visiting happen where it's safe to do so. This is particularly, of particular importance through Christmas and over the festive period where even more people are likely to want to see their loved ones. We've been clear throughout the pandemic, providers should follow government guidance, and if we hear instances of blanket approaches, we will take action. We had 54 concerns raised to date around 50 locations, and each one of those were followed up to address that. We've done 10,000 inspections since the start of the pandemic in adult social care. And on our care home inspections, we look at visiting as a component of each of those inspections. We've had some examples recently about providers issuing a general policy on visiting. We expect providers to follow government guidance and things such as the essential caregiver, we would expect for them to be able to visit in most circumstances, even if the care home is experiencing an outbreak. And to just link back to our earlier conversation, as we think about how we can enhance the number of IPC inspections we will be doing in the new year, when we do IPC inspections, we will again be having a really good look at how providers are making visiting happen as well. Thank you.
Thanks, Kate. And Ted, do you want to just touch on secure units?
Yes, thank you, Peter. So as in social care, we expect providers to follow the appropriate infection control guidance. That doesn't mean blanket bans on visiting. Clearly, they need to take into account the needs of individual patients, but equally, they need to risk assess visiting individually, so they build around the needs of individual patients. We discussed this actually in our recent publication review of the Mental Health Act, which colleagues will remember, and on that occasion we responded to patients raising concerns about visiting and made sure that the provider was allowing visiting to patients where that was appropriate to do so. This is something we've very much focused on in our assessment of the Mental Health Act review, and if people want to know more about it, then I suggest they look at the Mental Health Act review document.
Thanks. And the second questioner was Bren McInerney, and Bren made me promise I would read out an opening statement as well as a question, and rather than have my knuckles rapped by Bren afterwards, I will do so. So Bren's opening statement was, please may I offer my sincere thanks to everyone at the CQC for all their relentless and tireless work and for consistently working with the principles and values that you should all be very proud of. I am certainly very proud of you all. I offer my sincere thanks and wish you all well for the coming seasonal period, as I do for the 365 days a year ahead. So thank you, Bren, for that. And then Bren went on to ask, I think, a rather important question, which is, does the CQC look at the triangulation of safeguard reporting with that of, for example, speak up reporting, and how will safeguarding reporting be examined in the landscape of integrated care systems that formally come into being in April 2022? Rosie, do you want to respond to that?
Yes, thank you, Peter, and thank you, Bren, for those kind comments and your continuous support you give to the board. It's very much appreciated. So we take account of all of the information we collect, which includes statutory notifications, complaints, safeguarding alerts and concerns, freedom to speak up concerns, as well as whistleblowing information. And we take all of that into consideration when we evaluate and assess risk. This information absolutely informs our decisions about the regulatory action we take. As we develop our ICS regulation, this is something we will be considering in terms of how we look at safeguarding going forward. And I know that's also a consideration with the work Kate's doing around local authority assurance. Thank you.
Thank you very much, Kate. Thank you, everybody. That brings the public board meeting to an end. We've finished